Hi and welcome back to another video of Medic Notes. This video is on hepatorenal syndrome. For introduction, hepatorenal syndrome is a multi-organ condition affecting the kidneys and the liver. It is a cause of acute kidney injury that can be seen in those with acute or chronic liver disease. The incidence of hepatorenal syndrome in patients with decompensated liver disease is approximately 4%. Most of these patients have portal hypertension from alcoholic hepatitis, cirrhosis, or metastatic cancers. The cumulative probability of developing ours at 1 year is 18%, and at 5 years is 39% in patients with decompensated liver disease. For etiology, viral hepatitis is the most common cause of liver failure, thus hepatorenal syndrome, in developing countries. Most commonly, it is caused by hepatitis B or, less commonly, hepatitis C in the developed world. The most common causes are drugs and medications. Most commonly acetaminophen, chronic alcoholism, or any drugs that induce cytochrome P450, and non-alcoholic steatohepatitis. Less common causes of liver failure leading to ours include viruses such as CMV, HHV6, and parvovirus B19. Alternatively, vascular phenomenon like hepatic or portal vein thrombosis, and metabolic causes such as non-alcoholic fatty liver disease. For its pathophysiology, cirrhosis and portal hypertension can trigger the neurohormonal cascade which leads to the development of ours. This, in turn, causes the production and release of vasodilators and cytokines like nitric oxide and prostaglandins, which cause splanchnic and systemic vasodilation. The systemic drop in circulating pressure triggers the carotid and aortic arch baroreceptors to activate 3 separate compensatory mechanisms. These include the renin-angiotensin-aldosterone system, vasopressin release, and activation of the sympathetic nervous system. The progression of the cirrhosis causes the fall in cardiac output and the fall in systemic vascular resistance in a cycle that induces further renal vasoconstriction. This leads to further renal hypoperfusion, worsened by renal vasoconstriction with the endpoint of renal failure. Clinical features: patients with hepatorenal syndrome present with signs and symptoms of severe liver failure. These patients initially can present with fatigue and lethargy which can be multifactorial. This may be contributed to by loss of appetite due to increasing nausea. Over time, patients become increasingly more jaundiced, originating in the sclera and then spreading from head to toe. The liver's synthetic function becomes affected, and patients become coagulopathic and more likely to bleed. As all this occurs, there is a very slow, gradual buildup of acidic fluid in the peritoneum due to the intravascular loss of albumin. Confusion due to hepatic encephalopathy is likely the last and most severe stage of the liver disease, as a result of the liver failing to break down toxic metabolites. Most importantly, these patients notice they urinate less frequently in smaller and smaller volumes as they become oliguric. Hepatorenal syndrome has 2 types and is a diagnosis of exclusion. Type 1 is characterized by rapid and progressive decline in renal function, defined by doubling of the serum creatinine to at least greater than 2.5, or a decrease in the creatinine clearance by half or more over a 2-week period. This is usually associated with a urine output of less than 500 milliliters per day, a normal urine sediment, and a low urinary sodium excretion. Type 2 typically involves less severe kidney injury, and patients ordinarily present with diuretic-resistant ascites. Other apparent causes of acute kidney injury need to be excluded, including pre-renal, nephrotoxic drugs, obstructive nephropathy, and renal parenchymal disease. For treatment, first and foremost, ours involves establishing euvolemia while stopping all nephrotoxic agents. The active medical treatment of ours is directed at splanchnic vasoconstriction, which results in increased systemic vascular resistance and mean arterial pressure. This via counter-regulatory mechanism suppresses the renin-angiotensin-aldosterone system, ROS, and the SNS. In turn, this reduces renal vasoconstriction and improves renal blood flow. This is achieved with several different combinations of medical therapy. In Europe, a combination of terlipressin and albumin improves renal perfusion in patients with ours type 1, and can work in some patients with ours type 2. In North America, noradrenaline and midodrine or octreotide are used for the same purpose as terlipressin. When medical management fails, surgical management involves placement of a transjugular intrahepatic portosystemic shunt. This type of surgical treatment is established with the insertion of an intrahepatic stent to connect the portal vein to the hepatic vein. The shunt redirects portal blood into the systemic circulation, reducing portal pressure and increasing systemic venous return. This reduces the arterial hypoperfusion and thereby downregulates stimulation of the ROS and SNS. Definitive treatment for ours is established through liver transplantation and provides the best long-term survival benefit. Prognosis for type 1 ours is poor, with an average survival of just less than 2 weeks. Type 2 ours survival is dependent on the severity of the Child-Pugh class of liver disease, but generally more chronic, and median survival was 6 to 12 months without treatment. Complications of hepatorenal syndrome will be renal failure and even death. That's all for this video. Thank you.